We are starting the last session of the afternoon, the first session of the afternoon talks. And it's an important topic, endocrine and bone health issues. I think that they have been always important, but now in the era of gene-modifying therapies, it became more of at least as a clinician, I get more of the questions, what do we do, how we intervene, are we doing the right thing? So I hope that we can all learn more about this. And for that, we have the pleasure to have Dr. David Weber, as well as Dr. Leanne Ward. Leanne will participate online. So with that, and further ado, you have the mic. Thank you.
Thanks, everyone. And thank you so much again for the invitation. This has really been a wonderful conference, and I've learned so much, and so I'm very excited here. So yeah, we're going to talk about endocrine bone health issues in DMD and SMA. Leanne and I are going to tag team this. So I'm going to really start off talking about some background and then kind of going through some of the current standards of care. So I really want you to become familiar with the pathophysiology underlying the bone and the endocrine disease and neuromuscular disorders. Talk about the impact of chronic steroid use. This, again, a focus towards DMD. And then understand the current clinical approach to managing the endocrine and bone health issues in these patients. And then I'll hand it off to Dr. Ward, who's going to move us forward into the future. So let's just start talking about skeletal fragility. This is probably what comes up the most in practice and perhaps the most severe. And these conditions really cause a severe secondary osteoporosis. So we have muscle weakness, we have immobility, and in the case of DMD, of course, we have high-dose steroids. These cause long bone fractures. So here's a distal femur fracture. This is actually a boy with DMD, but these fractures are quite common in both kids with SMA and DMD. Of course, fractures impact quality of life, participation in activities of daily life, school. They can result in premature loss of ambulation in those boys with Duchenne or SMA sort of teetering on that. And then in DMD, there's the risk of that fat emboli syndrome, which is probably one of the leading causes of early mortality in boys with DMD. And then, of course, we have steroids, and so the classic fracture of steroids is a vertebral fracture. This impacts quality of life, pain, positioning. We heard a lot about kyphosis, and I think it's a vicious cycle of kyphosis, weakening those bones, and then fractures worsening the kyphosis. So really important. And fracture risk is quite common. In fact, it's almost universal in these conditions. So there's been several studies looking at this, the natural history of fractures, showing you here one from Scotland. This is just fracture probability over life, and you can see that 80% of these boys had a symptomatic fracture by age 20. And a really important thing I want everyone to take away is that the risk of fracture actually increases after loss of ambulation. I think there's some misconception out there that once you come off your feet, you're in a wheelchair, you're not going to break. That's actually not true, and the opposite is true. So we still have to pay attention to bone health when we lose ambulation. Fracture risk in SMA is less well characterized, and this is a theme you'll hear from me. We just haven't studied the bone effects of SMA as systematically as we have for DMD. Hallie Wasserman has a study here looking at 85 subjects with SMA 1, 2, and 3. The fracture risk isn't as great as Duchenne, but still the majority had had a fracture by age 20 years. Again, that femur fracture being the most common. Femur fractures are very uncommon in typically developing children, so these are very unusual and severe fractures. So what's the pathophysiology of skeletal fragility here? So let's start in the middle. So fracture, of course, that's the clinical event that we're trying to avoid. And I think there's really two main pathways to get there. One, we have deficient bone accrual, leading to low peak bone mass, which increases that risk of fracture. And then secondarily, one that's harder to quantify and qualify even is this impaired bone quality. So these bones, not only is there less bone, but it's not as strong. So that leads to diminished bone strength. And so what are the effects of this? So the neuromuscular disease, we have those muscle effects, the weak muscle not pulling on the bone. We have immobility, lack of weight bearing, falls, and some abnormal bone remodeling. And then for steroids, we throw in a whole host of other things on top of that. Increasing risk of vitamin D deficiency with the weight gain that comes with steroids. We get some excess urinary calcium loss. We have hormone deficiencies. We'll talk about hypogonadism and growth hormone deficiency. Steroids are directly toxic to the bones. They cause insulin resistance. They cause changes in body composition, and they impact the vascular supply to bone as well. So really just overall lots of threats to the bones. And this is a great study from Nikki Crabtree just showing what happens to bones when you lose ambulation. So this is a technique called peripheral quantitative CT. Gives you these very nice images of the bone. This is a lower extremity, a tibia and a fibula here. And so across the top is a typically developing boy who's walking, and you can see that those bones remain robust over time. This is a boy with Duchenne who remained mobile. You can see the bones are smaller and there's less trabecular bone. That's the red in the middle. And then contrast that to a boy who loses mobility. It's that dramatic loss of trabecular bone, and that really is contributing to that fracture risk. And so what about steroids? So steroids have both an acute and a chronic negative impact on bone. This is important because that fracture risk starts within a year of starting the high-dose steroids, which is why it's important to do that screening early. And that's because when we start high-dose steroids, we actually see an increase in the activity of these osteoclasts. Osteoclasts are the cells in the bones that resorb or break down bone, and so we give steroids, we make them more active, and so we can actually see this rapid bone loss even. And then over time, what happens is the whole bone just kind of shuts down. So steroids lead to what's called a low bone turnover state. So we see depressed activity of the osteoblasts. Those are the cells that build bone. And in fact, even worse than that, we heard a bit about this morning. What happens is those cells that should be forming into osteoblast bone building cells actually turn into fat. And that shows up as increased marrow fat. And together, the low bone formation, the increased amount of fat in the bone, weaken the bones further. So let's talk about vertebral fractures. As I mentioned, these are essentially a near universal complication of classic daily corticosteroid use. Leanne Ward is going to talk next, and she's really been the leader in her group in really defining the impact of steroids on vertebral fractures. In a recent paper they looked at, even over just a 12 months in a prevalent DMD cohort, showed that 45% of those boys developed a vertebral fracture. And they have some images here that show a baseline and a 12 months, just sort of illustrating what we see. So oftentimes, these aren't like an acute vertebral fracture that happens like in a car accident, something like that. It's just a loss of bone in the spine. And that loss of bone in the spine, that depression there is really what we're looking at as that sign to say, all right, it's time to intervene with medicine. They did look at this, and a couple things to note. The prevalence of a fracture in this cohort was higher than what was seen in other kids on high-dose steroids, so they compared it to rheumatologic diseases, pediatric leukemia, and they found that the degree of bone density deficit, having a bone age delay, were associated with greater fracture risk. And one thing that's important to know is if we don't intervene early, we just get this progression, what's called the vertebral fracture cascade. You can see here a boy who has multiple level vertebral compressors, and so this just goes on if we don't intervene. Again, they get more kyphotic and just builds up that pressure, and they can collapse the whole spine, and this can be very painful. We've seen this, take kids, who are walking, some kids with Becker who are walking, and they can't get out of bed because they're in so much pain. And so we're really trying to prevent this from happening. So I'm going to switch gears here and talk about clinical care. We heard about the care considerations earlier. There's a couple of things to note about them. So really, the goal is to standardize and ensure a minimum level of care. And these guidelines actually were really important for the endocrine and the bone field. It's the first time that they were really put out there and given some really clear recommendations. And when we talk about the bone health, we really kind of broke it up, and I should say myself and Dr. Ward contributed to these. And we really thought about the bone health as a monitoring phase. And so this is identifying these patients at risk of bone health issues and monitoring them closely. And this really does need to be initiated at that start of steroid or shortly thereafter. And what we're doing is we're taking careful fracture histories, and then we're looking for signs of vertebral fractures. And we do that physically with palpation of the spine. We're going to do some basic bone biochemical monitoring. We want to make sure we optimize our vitamin D levels, of course, important for calcium absorption. And then the big change, and really the critical thing here, is we want to institute our vertebral fracture assessment or monitoring for those compression deformities early with a lateral spine radiograph or a DEXA scan every 1 to 2 years after starting steroids. And this really does need to begin within that first year of starting high-dose steroids. DEXA scan is also important. It's probably less important than the spine x-rays, to be clear, but we still will use that, and we'll look at the changes in bone density as another marker of things getting worse. And so we do recommend doing lumbar spine DEXA scan, again, every 1 to 2 years within a year of starting steroids. And then depending on where you practice, your center may offer other DEXA sites as well, like the whole body, the lateral distal femur, which give us some more information about bone health. Just to talk a little bit more about vertebral fracture assessment, or VFA, as I mentioned, this is often that initial clinical manifestation of skeletal fragility and steroid bone disease. These are usually atraumatic, so there isn't that fall or there isn't that time point that you can point to. And they're progressive, as I mentioned. We do them by radiograph, assess them by radiograph or by DEXA. And really, in a perfect world, these are classified by location and severity. I know the group at Stanford here has an excellent program for this, and will give you high-quality spine reads. The care considerations guideline, as well as the International Society for Clinical Densitometry, recommends that vertebral fractures be classified using the Jeanette method. Won't go into too much detail here, but you can see really it's just the idea that each vertebral body is graded according to the degree of compression, and then allows us to track those changes over time. So it just gives us a way of quantitating this and following. And so here's an example of how that might look in a clinical scan. And then once we sort of move into the bone health treatment phase, and so at the time of the care considerations, these really were meant to be based on the evidence, and there wasn't a lot published at the time, and so they're a bit conservative. But at that time, the standard practice was to start treatment with a bisphosphonate when we had that first low trauma long bone fracture, so that, minimally traumatic fall in a broken femur or a tibia. If there was a symptomatic or a painful vertebral fracture, or if we had a asymptomatic but moderate to severe vertebral fracture. There were some recommendations there about the asymptomatic mild compression fractures, about maybe treating or maybe following. It was a little bit less clear. And Dr. Ward's going to talk about this, but our practice has really shifted in the 5 years since then with more data, and we're being much more aggressive and really starting treatment for those early compression fractures. And then in terms of the agent, the care considerations really recommended using IV bisphosphonates, so zoledronic acid and pamidronate are the two most commonly used here in the States. And the idea is that you treat with a higher dose up front, you kind of stabilize the bone density, stabilize the spine, and then once things are stable and the kids are doing better, then we back off on how much we're giving and how frequent we're dosing. There's a fair amount of data supporting bisphosphonate use at this time, so we've been using these drugs for 40 years in children, so we have a good sense of how to use them. These are strong medications, and we do have to be thoughtful. They cause an acute phase reaction with some fever, some nausea, some vomiting, some myalgia with the first treatment. It can cause some transient hypocalcemia. For the kids with Duchenne, we have to always think about adrenal insufficiency, and so typically we do some stress dose steroids around the time of these infusions. They've now, since the guideline has come out, there's been some placebo-controlled trials, for the first time really showing conclusively that they are better than placebo for improving bone density and steroid-induced osteoporosis in children. And then small studies have actually shown beneficial effects in the spine. This, again, comes out of Leanne Ward's group. And here's someone who was treated with bisphosphonates, a boy with Duchenne, over 24 months. So you can see those spines getting better, right? Those vertebral bodies getting thicker, it's stronger, it's more resilient. So not only do we see the bone density going up, we do see some improvements in the spine. I will say that this is, you're gonna get much more improvement like this early on in the disease course when they're still growing. Once they're done growing, there's less opportunity for reshaping of those vertebral endpoints. Just real quickly, want to talk about growth in puberty. This has come up in a couple of the cases. DMD causes slow growth even before steroids, so these guys are shorter than would be expected based on mid-parental height. But it's really the steroids that cause the great issue. And so here's a growth chart from one of my patients. You can see before starting steroids, they're around the 50th percentile, started their prednisone, and then really just slowed down. And then once they became wheelchair dependent, really very little growth. And so very dramatically short. This has been quantified. So one study showed that kids on daily prednisone were 10 centimeters shorter than those who were untreated. There's a lot of controversy about using growth hormone, and this will come up, I think, in Dr. Ward's discussion about vamorolone. So there's some concern that growing faster and being taller may actually stress those muscles and hasten some of those declines in muscle function and ambulation. And so because of that, growth hormone is not routinely recommended. You know, there certainly are some boys and some families who are very upset by their size, and we'll have that discussion. We'll talk about the risks, we'll talk about the benefits, and we have treated with growth hormone, but it's not a routine recommendation. And then puberty is the other thing that we've really recognized as important. So high-dose steroids essentially stop puberty from happening. It shuts down the hormones that signal the onset of puberty. And so most of these boys on daily prednisone or deflazacort will need testosterone to go into puberty. And we do recommend that starting around age 12 to 14. This is a discussion like many things with these families. There's a lot going on, and this can come as a shock to some of the families. And so really we start talking about this even before then with the idea that, you know, we may need to have some hormone help to kind of get you into puberty. There's still some uncertainty into whether we need to continue testosterone in these boys after they get through puberty, so we're still learning. Other endocrinopathy, just half diminished adrenal insufficiency. It's so important. So both classic and the non-classic steroid vamorolone cause adrenal insufficiency. So we really do want to make sure all these boys have education, these families have education around stress dosing and emergency action plans for illness, and making sure that steroids are tapered and not stopped suddenly. And then from the cardiometabolic standpoint, we worry about the weight gain related to the steroids. There's some new medications out there you may have heard of course, Wegovy. These things are quite common. We're just starting to think about using them in our boys with Duchenne. There's some considerations there. Hasn't been well studied, but important to think about. And I was very excited to hear about the exercise interventions today. And I think just anything we can do to get these kids, more active, when they're able is fantastic. So for SMA then, not as much in terms of the bone health care considerations. Again, just there's been a lot less attention paid to this, I think, from our end. The care considerations did mention bone health monitoring. They did recommend annual DEXA scans. I talked about vitamin D assessment and repletion, and then talked about bisphosphonate therapy in cases of recurrent fractures. Real quick, DEXAs are really actually tricky to use. They're tricky to order. They're tricky to interpret. These patients have scoliosis, they have contractures. You can't always get a standard DEXA scan site. Your DEXA lab will be able to help you with this. So the 2019 DEXA guidelines did offer some tips for how you can do DEXA scans at other sites. So we can scan the forearm as another way of monitoring bone density. And we can do a distal femur, which can be done with the knee bent, which is helpful when there's contractures. So there are still options for doing DEXA monitoring, even in older boys, but it does become tricky. In terms of the management of SMA, again, not a lot published. The Cincinnati group, again, Dr. Wasserman's group, did report their use of bisphosphonates in kids with SMA. They did show that it was successful in reducing the fracture rate from 1.4 to 0.1 fractures per year, and they saw a trend toward an increase in bone density, but this is only 8 patients, so it's a very small study. Anecdotally, this is an extremely hot topic in our listserv is always, should we give bisphosphonates before scoliosis repair? And so this, I think, was sort of always a bit of a taboo subject in the open until recently because this idea we weren't really treating ahead of fracture. But a lot of centers have developed protocols where we'll give a couple doses of zoledronic acid before that surgery with the idea of making that bone harder, hopefully stopping some of those issues with migration of the hardware that's in there. But today there's been nothing published on that. Some impact of, I think this is the big question where we're heading is how is the changing natural history and disease modifying therapy going to affect our bone outcomes, and starting to see some of this. So here's a paper in SMA looking at 20 subjects with SMA 2 and 3 on nusinersen. Overall, they didn't actually see a clear benefit on bone density. What this is showing is a change in the Z-score. So is their Z-score improving or catching up, or is it getting worse and falling behind their peers? So they didn't see any major differences there, no significant increases in bone density Z-score were seen in the 2 years after nusinersen. And they also didn't see any change in the markers of bone formation. This is an interesting paper I found. We heard about the growth-friendly spinal implants, and again, just getting at this idea of should we be treating these patients with bisphosphonates. And the first thing that they did is they compared the bone mineral density. This is using CT scan, so it's a quantitative CT to give bone mineral density of each of the vertebral bodies. And you can see here that the individuals with SMA, either whether they got the growth-friendly spinal implants or they had not had implants, had significantly lower bone density than healthy controls, which of course makes sense. But the interesting part of the study is that they showed that those individuals who had those surgeries, so they had hardware in there, actually had lower bone density at those vertebral bodies than those who had not had surgery. Of course, maybe this is confounded because that's just a sicker group, but it raises the question, is there something actually happening after that surgery to further weaken those bones? So important area for further discussion. Really not a lot about growth in puberty and SMA. These are not common complications. There's actually SMA-specific growth curves out there, so it is possible to follow growth for kids with SMA compared to sort of a normative data. There's one paper I found looking at puberty, and they did find that cryptorganism or delayed descent of the testes was common in SMA type 1, but beyond that, pubertal timing and completion did appear normal in an SMA population. This is not something I see clinically much. So I'm going to end here summarizing the current minimum care. So really emphasize the role of the endocrinologist and the bone health specialist, the dietitian, the physical therapist, the occupational therapist, making sure this is all happening, together in neuromuscular clinic. And I think we really want to start seeing these patients early. It's much better to start talking about this early in the disease course and then waiting until they've had that fracture.
My portion of the talk is really to talk about where we're thinking about heading on the background of everything that Dr. Weber just said. These are my disclosures, and my disclaimer is that all of the osteoporosis therapies that we're talking about today are currently off-label in children. So, what are we thinking as we move forward beyond 2023? And I am going to focus on steroid-treated Duchenne muscular dystrophy, but some of these principles will be applicable to SMA as well. I just want to really emphasize what David said, and that is that the endocrine and bone issues of steroid-treated Duchenne are indeed serious. We know that unexpected premature mortality in Duchenne arises from the fat embolism syndrome and also from unrecognized adrenal crises, and that's both published in the literature, and we're aware of that happening around the world. We know that osteoporotic fractures lead to permanent premature loss of ambulation in steroid-treated Duchenne, and that's absolutely devastating when that happens to families. And we also know that the obesity of steroid therapy can interfere with muscle function. And then there's this whole layer of psychosocial burden that arises from the various endocrine complications and bone issues in steroid-treated Duchenne. For example, the infantilization that comes from the profound growth and pubertal delay of steroid therapy. The premature loss of ambulation from fractures and obesity is, as I said, devastating. And then there's the burden of additional medical visits and treatment arising from endocrine and bone morbidities. And we're also thinking more and more about sexuality and fertility. The patient advocacy groups are asking this of us, and we recognize that this is an unattended aspect of the endocrine care in this context. Because the endocrine and bone issues of steroid-treated Duchenne are so significant to families and so potentially debilitating, we've come together as an international group of leaders in this area and formed a consortium that we're calling the Optimized DMD Consortium. And there are a number of individuals from the United States that are part of that consortium, as well as other parts of the world. And our goal is to improve clinical care, to continue to advocate for awareness in this area, and to develop collaborative research together. Now, I don't have time to talk about all of the sort of forward-moving initiatives in endocrine care with respect to steroid-treated Duchenne. I do, though, want to focus on where we're headed in terms of prevention of fragility fractures. So we're really trying to move the dial here, and we're moving from late secondary prevention of fragility fractures to early secondary prevention, which is the current standard of care, and now thinking about primary prevention of fragility fractures. That is starting bone protection therapy before first ever fractures. And this initiative will herald the first ever approach to preventing fragility fractures in any pediatric osteoporotic setting. So Duchenne muscular dystrophy is going to lead the way. I think it's helpful to really understand how we have shifted our thinking over the years as knowledge has evolved. So in 2010, the Duchenne care considerations recommended a spine x-ray if there was back pain or kyphosis, and then treating vertebral fractures if they were identified in that way with IV bisphosphonate therapy. So this was a late secondary prevention approach. And then between 2010 and 2018, this is when we learned that vertebral fractures are the hallmark of steroid-induced osteoporosis in children, and that they're frequently asymptomatic in their early phases. So we have to go looking for them. We also learned that you do not, in a high-risk setting, need to have multiple long bone fractures before you'll say that a child has osteoporosis. That a single long bone fracture, like a femur fracture, can be sufficient to say you have osteoporosis in a high-risk setting like steroid-treated Duchenne. So the 2018 care considerations were like this, that we recommended monitoring from the time of diagnosis or steroid initiation with periodic spine x-rays, and then to treat early signs of vertebral collapse with IV bisphosphonate therapy or oral therapy if IV was not available, and then to treat a first long bone fracture with IV bisphosphonate therapy and not wait for multiple fractures. So this is early secondary prevention. And when you monitor boys with steroid-treated Duchenne this way, you actually pick up vertebral fractures on average about 2 years after starting steroids and as early as 6 months. And then long bone fractures can occur literally anytime. So if you're really monitoring carefully, you will identify and treat boys with steroid-treated Duchenne really quite early in their disease course. But in 2023, we're really thinking about how we can prevent first ever fractures, given that the frequency of fractures is so high. As David said, virtually universal for vertebral fractures, and up to 60% of boys will have at least one long bone fracture. So that justifies a primary prevention approach. Now, I just want to sensitize you to the fact that it will indeed be difficult to prevent all fractures in this setting, even with a highly effective therapy, because boys with Duchenne can have fractures prior to diagnosis. That myopathy is operative in utero, and even in the toddler years, you can have osteoporotic fractures. So when you see a boy at diagnosis and ask about their antecedent fracture history, if they've had a fracture, that means they have osteoporosis even prior to being diagnosed. When we think about prevention of first fractures, we have a lot of issues to consider, and we don't have all the answers right now, but this is what we're thinking about. We're thinking about bone-targeted therapy. We're also thinking about effective treatment of the underlying myopathy, because the myopathy drives those thin, low-density gracile long bones, making them more fragile. And we're also further thinking about the impact of combination therapy, aggressively treating the underlying disease, but also adding in bone-targeted therapy. When we think specifically about bone-targeted therapy, we have to think about when to start and the choice of agent. When we think about disease-modifying therapy, ideally we will use an agent that is as steroid-sparing as possible. But in Duchenne, it's not looking like that's where things are going. It's looking like steroids are here to stay. And so the aggressive osteoporosis phenotype is looking like it is here to stay for the foreseeable future. In terms of the timing of bone-targeted prevention therapy, the earlier the better is the overall premise. And you may want to think about just very simple messaging, starting at diagnosis or starting at steroid initiation, or no later than 1 year post-steroid initiation. I think this is very appropriate. I think it may be difficult, though, for families to get their head around treating a comorbidity so early in the disease course. I also think some centers may have difficulty operationalizing an early treatment intervention. There also may be families and care providers alike who may want to have a little bit of clinical nuanced information in order to say, look, I really think you should start bone protection therapy now, even though you haven't had a fracture. So when we think about gathering some nuanced information to say, yeah, really, we need to get going, we can think of it in two ways: significant loss of muscle function, which of course is a risk factor for fractures, and significant signs of steroid exposure. We know that if the time to stand test in Duchenne is more than 5 seconds, that loss of ambulation is imminent compared to boys who can stand up more quickly. And then steroid exposure signs, of course, indicate that the boy has had enough steroid exposure to thereby have a negative impact on bone development and increased fracture risk. So what do we consider significant signs of steroid exposure? A bone age delay that exceeds 1 year their chronological age, so is more delayed than 1 year of their chronological age, a decrease in height Z-score of a half a standard deviation or more, an increase in weight Z-score of a half a standard deviation or more, Cushingoid features, the round face, the truncal obesity, and a decrease in lumbar spine BMD Z-score of more than a half a standard deviation or more. So one might want to wait until there are these signs that fractures are imminent. When we think about the choice of agents, we think about bone protection therapy being either anti-resorptive or anabolic. In the anti-resorptive category, we have the oral versus IV bisphosphonates. Of course, oral agents are attractive in the subclinical pre-fracture phase because they're so convenient. They also have fewer side effects, but that's because they're less potent. And in a condition where the fracture frequency is so high, I'm not sure we should be leaning towards the less potent agents, but that's something to think about. And of course, we have most experience with IV bisphosphonates. These are more potent, but at the same time, they do have side effects, as David mentioned, and those do need to be managed, including in a subclinical phase. Anti-rank ligand antibody denosumab is really not the direction we're headed in. We thought that the low bone turnover of steroid-treated Duchenne would protect against the denosumab-induced hypercalcemic rebound phenomenon, but it does not. And so while this was looking promising up till recently, we've come to appreciate through clinical trials that this is not going to be an option for us going forward, except in perhaps very specific circumstances. And then anabolic therapy, of course, is very logical in this low bone turnover state of steroid-treated Duchenne. Teriparatide no longer has the black box warning against its use in children. It is a relatively weak anabolic agent, however, so we need to consider that. It also doesn't work very well if it's given after someone has had anti-resorptive therapy. And then there's anti-sclerostin antibody, and this is the most potent anabolic therapy that is currently available. This is used to treat adult postmenopausal osteoporosis when the individual has failed bisphosphonate therapy. Anti-sclerostin antibody has not been used systematically in children. There are currently trials underway of the use of setrusumab and romosozumab in children with osteogenesis imperfecta. So we're really following that literature very closely to see how we might adapt the principles that are learned in OI from the use of anti-sclerostin antibody therapy to Duchenne muscular dystrophy. The first principle of chronic disease osteoporosis management, however, is effective treatment of the underlying disease, ideally with steroid-sparing agents. So the question is, how far can we get with really effective treatment of the underlying disease? People have asked whether tweaking the glucocorticoid regimen can be bone protective. So this is a very nice study by Jared Wong's group that shows that daily prednisolone and daily deflazacort had the highest rates of fractures. So you can see daily deflazacort had the highest fracture risk, followed by daily prednisolone. And then intermittent prednisolone and intermittent deflazacort were relatively bone protective, and the lowest fracture risk was with steroid naivete. The problem with intermittent steroid therapy, though, as you know, is that it comes at a cost to muscle strength. And that's been shown by the 4DMD group comparing prednisone 10 days on, 10 days off to daily prednisone or deflazacort. This concept was also nicely shown by Nikki Crabtree out of the UK. This is a retrospective study looking at the prevalence of vertebral fractures after up to 4 years of glucocorticoid use, whether daily in red or intermittent 10 days on, 10 days off, prednisone in blue. And just tracking to the far right, you can see that after 4 years, that 40% of boys with Duchenne on daily prednisone had at least one prevalent vertebral fracture compared to 8 who had the intermittent prednisone regimen, 8%. But that was, again, at a cost to muscle strength. So then what about the dissociative steroid vamorolone, where there's been this through medicinal chemistry, an effort to dissociate the good aspects of steroid therapy from the bad. So vamorolone was approved for the treatment of Duchenne in the United States in October of this year. It retains anti-inflammatory benefits, and it has been shown up to 3 years of use to be comparative to prednisone when at its highest dose, vamorolone 6 milligram per kilo per day, vamorolone 2 milligram per kilo per day did not show efficacy parity in a randomized trial relative to daily prednisone. So we have data to suggest up to 3 years that there's a favorable effect on muscle strength outcomes from the highest dose of vamorolone, 6 mg per kilo per day. And it does appear to improve some side effects, but not all. So it's very important to understand that we have some improvement in side effects, but there are side effects of steroids that are persistent. And the main side effects that have improved in the short-term data that we have are growth and bone strength. So I'm going to unpackage this for you. So vamorolone is distinct from the corticosteroid class because it lacks an 11-beta oxygen. So it's not a substrate for what's called the 11-beta hydroxysteroid dehydrogenase enzymes. And 11-beta HSD1 in particular mediates the tissue-specific adverse effects of steroids. So the fact that vamorolone is not a substrate for the 11-beta HSD1 enzyme is theoretically advantageous in terms of minimizing side effects. There's also no prodrug to active drug conversion. Vamorolone, though, is also antagonistic to the mineralocorticoid receptor, which may be beneficial in terms of heart health, and that has yet to be proven, but does become an issue when we think about adrenal suppression management. And I'll talk about that more in a minute. This is what we know about vamorolone, and I've just put it together very simplistically for you schematically so that you can really retain the different nuances that we're coming to appreciate. Vamorolone does normalize linear growth. The growth is normal. And the question is whether normal linear growth is actually good for bone strength. If you are normalizing linear growth and your long bones are longer, but they're not getting wider because of the myopathy, the question is whether they'll actually be more fragile over the longer term. We just don't know. But linear growth is normal, and for some boys, this is going to be really welcome in terms of the psychosocial burden of extreme short stature that we normally see with steroids, the classic forms. We know that bone turnover is improved on vamorolone. Bone turnover, when we measure serum bone biomarkers, largely reflects linear growth, but it also reflects what's going on to a lesser extent at trabecular surfaces. And so if bone cellular activity is healthier, then we would expect the bone to be able to better adapt to mechanical loads and also to more quickly repair. And we know that vamorolone reduces but does not eliminate vertebral fractures. Vamorolone does not prevent excess weight gain. So if you had a tendency to gain weight on classic steroids, you will have a tendency to gain weight on vamorolone, and it does not prevent adrenal suppression. And this is unfortunate because the adrenal insufficiency of classic steroids is a complication that is life-threatening. We also can't use vamorolone for stress steroid dosing because the equivalencies at the adrenal level are unknown. As well, vamorolone is antagonistic to the mineralocorticoid receptor. And remember that classic steroids have mineralocorticoid activity, and that's what you want when you're in adrenal crisis. You want mineralocorticoid activity to maintain your blood pressure when you're in a stress situation. And then we don't know if vamorolone has a similar effect on muscle strength long term. as daily steroids, classic forms. We don't know if it normalizes pubertal development, and we don't know if it reduces long bone fracture rates. We just simply don't have the data. Now, here's some of the specific data from the trials that are in press. So this is the Vision DMD study, where in the first 24 weeks, boys with Duchenne were randomized to prednisone, 2 doses of vamorolone or placebo, and then in the second phase, in the 24 to 48 week phase, the patients who are on placebo or prednisone were crossed over to vamorolone 2 and 6 mg per kg. So what you can see in light blue and navy blue, vamorolone 2 and 6 mg per kg, is that bone turnover markers did not crash as they did on steroids. On classic prednisone, you can see that the bone turnover markers all crashed as we know them to do. And then when patients were switched over to vamorolone, there was a reversal of bone turnover suppression, shown here in peach and burgundy. And so both bone formation and bone resorption markers are invigorated on vamorolone. And again, we hypothesize that this will be beneficial for the bone's ability to adapt to mechanical loads and be stronger, but that has yet to be proven for long bones. And then here's the change in bone turnover markers over the longer term. This is over 30 months in boys. There is no comparative, so I'm just showing you the Z scores. We've benchmarked these 3 serum bone turnover markers to the healthy average by generating Z scores, and you can see that the bone turnover markers are normal at baseline and they stay within the normal range. So this is in stark contrast to what we understand with classic steroids, where bone turnover markers just plummet. And finally, this is the vertebral fracture prevalence data looking at vamorolone in the boys in the 003 long-term extension trial compared to boys who were in the 4 DMD study. So we're looking at vertebral fracture prevalences after 30 to 36 months of either prednisone daily, deflazacort daily, or intermittent prednisone 10 days on, 10 days off versus vamorolone. And although we're comparing 2 different study results, these vertebral fractures, their x-rays were read by the same radiologists out of my group over the same time period. So they are comparable. And we see that the vertebral fracture prevalence was highest on daily deflazacort at 29% compared to daily prednisone at 26%. We didn't see any vertebral fractures on intermittent prednisone at the 36-month mark, and then the prevalence of fractures on vamorolone was about 13%. So the fracture burden at the spine is lower but not absent on vamorolone. And then this is something called the Spinal Deformity Index, which is a measure of fracture number plus severity. So it's a measure of overall fracture burden, highest on daily deflazacort, followed by daily prednisone, and then lowest on vamorolone, although none were observed on intermittent prednisone. But of the daily agents, lowest on daily vamorolone. So my key takeaway points for you are that bone and endocrine morbidity is serious and warrants a proactive, early anticipatory approach to prevention. And through the Optimized DMD Consortium, we're really trying to move the dial on this. The myopathy largely drives long bone fractures, so the most efficient strategy to prevent long bone fractures will be effective treatment of the underlying myopathy with as steroid-sparing an approach as possible. Steroids largely drive the vertebral fractures. 10 days on, 10 days off. Classic steroids provide some bone protection, but at a cost of muscle strength. And early evidence suggests vamorolone may offer some protection against vertebral fractures, but we still recommend for now, until we have more information about this, to use the 2018 care considerations to monitor boys for bone health, even if they're on vamorolone. And then our International Optimized DMD Consortium is really now looking how to prevent first ever fractures in as many patients with DMD as possible. And so I thank my funding sources and my team for the work behind all of these results, and I look forward to your questions.
So this was excellent. Everything that I wanted to hear. Again, I think that these are very hot topics in our clinics. As a clinician, it's sometimes hard to have all the endocrinologists or bone health specialists on board, and because the families is a hard burden for the families to have to be looking for that endocrinologist that will attain to the guidelines. And so I hope that, having more education will lead us and more homogeneity of how we treat these boys, and also patients with SMA. So if there are not questions from the audience here, I have a few online. Are preventative fracture recommendations for DMD and SMA different from adults than in children's?
Yeah, I can start with that, Leanne, if you'd like. So there's quite a bit of difference in preventive treatment in adults versus children. So in adults, there really has been a premise of using DEXA and bone density thresholds to guide intervention of starting bisphosphonates or other bone protective therapy. We don't do that in kids for some of the reasons we talked about. It's just not so sensitive and specific as a marker of fracture. Adults also have FRAX, you may have heard of, which is a nice fracture calculator to help adults predict, the essentially 10-year fracture risk. I mean, that's something that I think would be very helpful for children, but we don't have that yet. So the result, so definitely it is different. Leanne, did you want to add anything?
No, that sounds great, David. I think, that's certainly the approach to the general population. I think in SMA, some very specific guidelines are probably needed that are even more nuanced than the approach in the adult population, given that the fracture risk is higher. FRAX was really meant for more the sort of postmenopausal adult population. So I think there's some work to be done there. And I think, David, you and I were both surprised by the lack of data on bone protection in SMA, weren't we? There really is a dearth of literature, and that's really wide open for discussion and research.
And this is a related question to that. What is the quote-unquote acceptable total Z-score for non-ambulant SMA children, if there's any?
We're really trying to move away from a Z-score centric way of assessing bone health. So I don't think there's a simple answer to that. Really, DEXA is most useful in tracking trends over time. So when we see patients who are having declining Z-scores, that's a worry. And if we see an absolute loss of bone density, that is an extreme worry because we're supposed to be gaining bone throughout childhood. So we're using DEXA as one factor in our decision-making, but it's based on fracture, it's based on muscle loss, ambulatory status, and then really trajectories over time. I don't know, Leanne, any other thoughts?
No, that's exactly it. Thank you.
I was curious if bone health biomarkers are commonly used in DMD SMA, and if so, what values do they add to the overall picture of bone health for these diseases?
Answer this because I don't use them, but I think you may.
Yeah, so I think David is right. Bone turnover markers aren't really used all that often. I do them routinely, and I think where they're helpful is they can teach us in the general sense in our bone health clinics whether a patient has a low bone turnover osteoporosis or not, and that may change our thinking in terms of the way we want to go forward with some of these therapies, anti-resorptive versus anabolic. So we're really interested in the anabolic therapies in the low bone turnover osteoporosis. Now, that said, we know that Duchenne is a low bone turnover osteoporosis, so you don't need to do biomarkers really to show that. I think where biomarkers might be interesting in the future is to see if they can help us better predict who's going to have a fracture before they have their first one. And this is something that we want to integrate into the Optimized DMD Consortium's research portfolio and try to see if we can sharpen things up a little bit by using additional tools like bone turnover markers. But that is yet to be, determined whether we'll be successful in that.
And one more from the online audience. Are there direct genetic contributions of dystrophy or SMN on bone biology that might suggest that genetic treatments of DMD or SMA will improve bone health?
Yeah, that's a good question. The short answer is we don't know the answer to that. I think clinically the SMA bone is different. The patients present a bit differently than Duchenne, so I think there probably are some differences. There's some basic science out there sort of, looking at the different effects sort of indirect on osteoblast and osteoclast, but I don't think we know that answer yet.
I would agree with that. Open for research.
I know for our adult population, interpreting Z-scores is fraught, and I don't think the FRAX scale really works for the adults. And I was wondering with the C-telomeric peptide, whether that could be a surrogate marker and if it's being looked at for use, because I feel like by the time I see them in an adult clinic, like everyone should be, probably should be on a bisphosphonate. So what are your thoughts?
I would agree that most of these patients should be on bisphosphonates by the time they get to you. Leanne, so what do you think about C-telopeptide as a marker in adults of bone fragility?
You know, I think it can be all over the place, and we don't have the data really to look at that relationship very specifically. But where we're headed overall, and this is where we are now, actually, and David alluded to this, we really gauge our need to treat and the timing of treatment based on what we understand about the relationship between the clinical context from a 50-foot view and the fracture risk. So we know, as David said 2 or 3 times in his talk, that fracture rates in Duchenne are extremely high. And that's why we're going to move towards prevention of first fractures, and the morbidity arising from fractures is high. So we're much more focused on the clinical context and what's known about its relationship with fractures, and then the fracture assessment itself. So, for example, we now prioritize a lateral spine X-ray over a DEXA. We have spent years trying to make sense of how to interpret DEXA, and as David said, our conclusion is look at the longitudinal trajectory, and you will see it go down in these myopathic circumstances. But before you wait for that to happen, look to see if you have evidence of fractures, and the spine is a telltale sign. So we've moved away from a DEXA-centric focus to a clinical context and fracture-focused approach. And when we do that, it's amazing how clear things become for us in the clinic.
Okay, and I think that you covered this in your talk, but what will make you decide versus oral and IV bisphosphonates?
So I think I use oral more than Leanne does. So I think this really comes into the discussion with the family. So for us at our center, and probably similar to you, we do have a lot of families who live very far away from us. And for some of them, it's just not practical to come in for these IV infusions. And so if you're having to drive 5 hours to come in, I think that may be one consideration. So, ability to get here for the infusions. Other things that we'll think about, severity. So for these milder cases that we're starting early, like loss of bone density, mild compression fractures, I think it's fine to start with oral Alendronate, and then if things progress, switch to IV. The other thing we didn't mention too much is we do have to think about the whole body. So some of our kids with more significant heart dysfunction can be at risk, higher risk from these treatments. So if there's a arrhythmia that might be affected by calcium disturbances, or if there's renal insufficiency that could be exacerbated by them, these are patients that maybe IV bisphosphonates may not be best for. I think another thing that both Leanne and I have started doing a bit more is even giving some Alendronate first to some of the patients to try to expose them to lower levels to reduce some of these side effects before we start IV Zol. Leanne, I think you've had some positive experience with that as well. Is that right?
Yeah, I've just started to do that based on Cincinnati Children's experience, where they have used a lot of oral agents. They set up their bisphosphonate program, my understanding, based on the adult paradigm, which is when you do use more oral, and they really reported fewer side effects than we see with IV. And so I had the thought that if we sort of prepare the body, if you will, with oral, shut down that osteoclast, which is responsible for secreting cytokines that bring about that first infusion reaction, and then use that lead in to giving IV therapy that perhaps we can attenuate the first infusion side effects. So I've just started doing that recently, and so far so good, but I think I need to see a lot more boys until I know the full sort of response to that approach of trying to attenuate the first infusion side effects.
My experience is the oral.
No, you go ahead, David.
I really think the oral Alendronate is kind of a stopgap. I do think things get worse on oral Alendronate for most of the boys on steroids, but it's a way to sort of ease into this as we're just going through helping them navigate all these complications, as you said. So I think it's better than nothing. It gives us some protection, but like we may need to move to more potent agents.
Yeah, thank you, David. I would just echo that. I sort of grew up, if you will, in the osteogenesis imperfecta randomized trial of oral versus placebo era, where we conducted a few trials trying to see, after years of IV use, whether we could actually use oral agents more often. And the studies were negative. They were negative. So I was witness to that knowledge kind of evolving when I was, in training and then as a junior faculty in the late 90s and at the turn of the century. And so it was for that reason that I really have gone forward with IV in my practice. I also gave alendronate in my younger years to some boys with Duchenne with painful vertebral fractures, and it didn't take away the pain anywhere nearly as swiftly and completely as IV agents. So I have viewed Duchenne as an aggressive osteoporosis and the need to be met with an aggressive treatment. But as we go forward with prevention of first fractures, where we have a little bit more time, I do think that a run-in with an oral agent to see if we can sort of mitigate those first infusion side effects is interesting. And I'm also going to look at the trajectory on the on the oral phase, and then how that changes when patients switch over to IV. And I think that will give us some information in the Duchenne setting.
Okay. As we're starting to treat patients, hopefully in the first quarter of 2024 with vamorolone, you mentioned that we should continue to monitor with the X-rays. Are we gonna be doing more DEXA scans? At least in our practice here at Stanford, we follow the patients with the Genan criteria with the lateral X-rays, more like the DEXAs. But is there anything different that you would recommend?
Leanne, I think you can take, yeah.
Yeah, I mean, as we've discussed, David, right now we just really recommend sticking to the 2018 care considerations in terms of the frequency of the X-rays. We do see that lower vertebral fracture prevalence after 30 months of vamorolone, but it's not zero. We don't know who will or will not have fractures on vamorolone, and we just feel that it's too early to de-escalate the monitoring until we have more information. We think we should monitor as we are doing, because the consequences of vertebral and non-vertebral fractures are so significant. Once you have one vertebral fracture, that's a setup for more, that vertebral fracture cascade. So in 5 years' time, hopefully David and I could come back and say, this is what we know about vamorolone, this is how we've been able to tweak the monitoring paradigm, but we just don't feel that we should be de-escalating till we have more information.
Definitely invited. I haven't consulted with the rest of the team, but I'm making that decision right now. Okay, thank you so much.
Yeah, thank you.
Thank you both. And with that, we will move very quickly to the next session.